where there are a lot of creators building an RHIS architecture, ensuring better interoperability between the subsystems, data quality, that's their priority. And that are Ethiopia, Malawi, Tanzania. They call them Gates Foundation at what you call health strategies then that we do to increase, as Dr. Cassette said, has been used and abused, but I think that we miss somewhere the point. Use of information is a behavioral intervention, both at individual level and at organization. Information culture, we have to transform information into, we're going to use a system already used way, well, in Ethiopia levels. Other strategies we have already talked about are the digitization of the various subsystems. Behavioral change is the capacity building of individuals in techniques like data analysis and problem solving, and organizational behavioral change. And that means, how do you govern your health information system? How do you have country ownership of this implement, believes in it, and acts as a role model? So my hope is that many countries in Africa and Asia will set up comparable initiatives, maternal, neonatal, and child deaths. Sorry that I went a little bit over my time. Thank you very much.
Thank you, Theo. So Theo has used and abused our long years of friendship in taking lots of time. The speaker would be Imad. Over to you.
Yeah, so when the right information is in the right hands, every country can overcome some of the challenges that we actually face so that we can actually improve care in our health systems. Next slide. Okay, so there are definitely, all of us know that there are several sources of data, several sources of information at the global level, at the national level, and definitely the difference is how we use this data. And so many times, actually, sometimes our policymakers, unfortunately, they are not here, but I hope this will be summarized. They sometimes make decisions not necessarily based on the data that we provide, but sometimes based on some political or social connotations that then make the data or information use completely useless. Definitely, better data use is very, very important in that it can improve the healthcare. It will help in terms of the use that data, of course, to deliver better health services as well. And of course, if you have some areas that are highly malaria endemic, like in Uganda, that's where you may focus most of the supplies. So unless you have the data, you cannot really focus on that. Then the policy slide. Oh, sorry, it's not at my 5 minutes. Path as a whole, we work in so many countries and work at 4 different levels. At the community level, just to emphasize, it's mainly empowering citizens to basically use data to demand for better health services using through the health management meeting committees. They sit with the health workers and review the data. They look at the trends. They draw simple graphs to actually interpret the data. And then they have those dialogues over and over. And when they supplies. Now, at the national level, it's basically we told the different stakeholders the budgets using that data. The lessons learned on those, the next slide, last slide. Yeah, what we've really learned over the period is that data is very critical in neighboring countries to dig deeper and looking at different. And lastly, CSOs are very, very critical in this process. They should also be involved in the data collection and data analysis and information sharing.
So, the next speaker would be Dr. Jennifer Rikwejo, Technical Deputy Director, Countdown to 2030. Dr. Jennifer Rikwejo is the Technical Deputy Director of Countdown to 2030, School of Public Health. Dr. Rikwejo's work in nutrition. She is also a member of the Independent Expert Group for the Global Nutrition Report and a member of the Steering Committee.
For the past and are currently involved, So many others could be up here doing this. Countdown to, it was originally Countdown to 20 series. Basically, there was a sense that effective interventions are available and widely well known. Coverage levels of those interventions were unacceptably low, and there was a sense in the international community that more noise was needed to be made about this fact, and so this was how Countdown was born. Countdown is a partnership model, so this includes the involvement of government iteration. It closed Countdown to 20 and Countdown to 20, the use of evidence for coverage for women's, children's, and adolescents' health. Countdown focuses where the burden is the highest. Right now, our list of countries is 81, and these are the countries that account for 90% of child deaths and 95% of maternal deaths. Next slide, please. So this picture, I'm sure you all can't really see, the font size is small, but it's meant to give you a sense of the framework of Countdown to 2030. So starting from the right, the aim or the overall objective of the initiative is to provide evidence for action to improve women's, children's, adolescents' survival and life. In order to accomplish that, the first objective is improved monitoring. Second is the building. To the left, it's organized by a secretariat. Next slide. There's, as you all know, the SDG agenda. As Flavia noted yesterday, at the heart of the universal health coverage in trying to advance methods like linking existing survey data sources with facility survey, up with new measurements for conflict settings and other. Already mentioned, there's a big focus in the new county level to assess data quality, analyze available data, and improve interpretation and use of data for decision making. Next slide, please. This is an example of our country profile where there's been progress and where more work is needed. Next, it's a means for us to be able to hold all of us to account for progress. And then at the same time, this has to be happening in tandem with strengthening country health information systems. This will be a longer-term vision to make decisions on where to allocate.
Mr. Philip Roberts. Mr. Roberts has overseen Coca-Cola Company. He became the project.
Be reapplied in. We basically use these incidents, Department of Health in South Africa, in establishing. We've done this program in 2014 with 180,000 patients. As of this week, we're at 1.8 million patients collecting medicines from anywhere other than a health facility. It allows the health facility, the demographic and sociographic of the patient population.
Oversees the management and the analysis of PMA, is a co-primary investigator of the PMA flow.
About PMA 2020, we can go to the next slide. Data and work with other systems. So PMA 2020 is a large-scale survey platform in local communities to monitor the family planning supply side in Ethiopia, Uganda, Kenya, Nigeria. Survey, which Dr. Kisete just read, a survey on nutrition, the southern nations, nationalities, and peoples region of specifically to link with HMIS records to CMIS records. Next two-page brief that we will disseminate. This is the information and it also includes information on the service delivery.
So we have come scorecards to and how they try to bring a culture change, the quality of routine data, which at the Mugisha from Uganda, he always jokes. Dr. Mugisha has really talked about explain the patients. All of you do not have necessarily to respond to this question. We have a number of data sources, globally, nationally, subnationally. So how do we improve the synthesis and analysis and use of these different sources, which at times give us very paradoxical results? So how do we improve the use of various sources of data, improve quality and use it?
Thank you very much. I think the question is very relevant. And to my mind, if we really want to use the global data, and the important thing is that the kind of the case definition, and then the whole quality checks should also be put in place. Some kind of that somehow, we as the policymakers, the people who are.
Theo?
Just quickly, standard architecture where you can have all these various sources talking to each other with health information exchange, but it is will ultimately improve better exchange of information between these various sources. And naturally, we need to do the triangulation. Several examples were there where you can compare various outcomes of indicators of.
Question, what if you have to give one advice to a minister, what would that be? Just one. Would like
The same easily available, make it easy to read.
My data is actually collected. You don't get back into, using data, and definitely don't rely on one source. I think that's the most important thing. Sometimes when somebody does a research, maybe it has some biases or in one small area, and wants to use that data to drive policy. So I think for the ministers and the policymakers, it's basically trying to kind of understand and get one source of data. Thank you.
So those are two advices. Dialogue on the data and don't rely on one source. Okay, who would like to intervene? Dr. Ajay?
Yeah, data use is basically, a culture of using data.
Theo?
To build on this dialogue issue, a regular inclusion of something like a score, that discussion that
Use data also invest of survey organizations such as PS and not organizations, I think would.
Ready to use at all levels. Very good.
Je vais m'exprimer en français. Élever d'indicateurs. Exploit to analyze indicators. And the second is for no, état civil. Yeah. L'état civil. And how we do to exploit, to analyze.
From Mali?
In our health sector. I wonder if, because I haven't heard anyone talk about the districts, and when we had this recommendation on how to improve the system, we use measure evaluation project to introduce, as I said, the district health information software and roll it out in the country. So I don't know, no one talks about it, and I know that this software has been introduced in other countries, such as Burkina and other countries. Something that should not be scale up in verification.
Relevant the local level. What is that? And so Dr. Ajay?
I think very well said that we keep collecting lot of data sets without using it. So I think the important thing is whenever we start collecting the data, we must have the objective clear in mind, because somehow what happens, the policy makers, they want every answer from the data sets, which is not possible. These particular expectations are that we should be able to get every answer. So that means the message is that HMS system objective should be very clear, that what for the system has been put.
Talk about routine health information system as HMIS. We couldn't touch everything, but I agree with you. The whole management standard one in so many countries is DHS2 with measure evaluation. I was involved in the Mali move into using DHS2 for HMS management. It's a robust application, and I think it helps very much in good of.
Thank you very much. Fantastic panel, fantastic responses. I would really like to thank you all. We have all, heard be used and responsible.
Once the heads of delegations and ministers have actually joined us. And then a reflect will for us announcements to make. As we described yesterday, there are 5 side sessions organized, starting from for 1 hour. There are 5 approach and selected interventions that will be on conference room number 4, which is outside this venue. And the next 3, which is a discussion on sources of sick child care, analysis of DHS data from the 24 priority countries, and a call for public and private partnership to co-create innovations would also be discussed. And achieving the vision of SDG for child health will be discussed in the briefing rooms 2, 3, and 5, respectively. You are all kindly requested.
This is. I don't think we are going for another session. Huh?
A picture. Here.
Comme ça, I begin with the president.
Let me pass before you take a picture of the president.
Just a moment, I'm passing. Thank you. Okay. Okay. The president.
هاي مكاعد
ma halkan gal soo dhawo sidii marka
I will. I will. Please let me first take mine. Wait me for me. Okay. كيف قفت موبايلك؟ In your back. What deep? So full.
You brought out the salient issues.
One more, 2 more minutes. ها؟ هيك towards you korka xaggaaga gee boqol jeer dhac la dhaconado taataaba kun jeer labadaadu What? This one. because it's last memory.
We're going to get started in a Okay, I think we're going to get started. We have moved down a level to be a little bit more intimate for the side session. I am Kelly Saldana. You may remember from yesterday. I'm the Director of the Office of Health Systems at USAID. I'm here with my colleague, Rob Cohen. He's the Senior Monitoring and Evaluation Advisor for MCH at USAID. We're going to go through the report for this year, the 2017 report, and then hopefully we will have plenty of time for questions and answers. And before we get started, I just want to point out that we get into the methods, how we did that, but a lot of the work is built off of UNICEF's Equist tool, and they're really responsible for a lot of the thinking that enabled the ability to even produce these numbers. So I want to give a big thanks to UNICEF. Next slide. So we talked about this, I think you saw it yesterday, in the evolution of the Acting on the Call work that USAID and partners have done. This year in the report, given that it's our fourth one, we were able to but really the focus of this year's report was on health systems. It represents an arc between the work on acting on the call in each of the reports, from focusing first on the key interventions, which we used modeling to demonstrate would be the most impactful for saving 15 million women and 600,000 women by 2020. Then, so we did two reports, one on the child health interventions and then one on the maternal health intervention on the most vulnerable populations, in specific the bottom 2 quintiles. And then building on that, this year's report takes another critical area, looking at the health systems bottlenecks and how health system strengthening interventions are also critical to the wider objectives and being able to alleviate those bottlenecks and help save the lives. So we're really excited because it's the first time that anyone has ever directly linked health systems interventions to lives saved. They've been intuitive, and people, I think, those of us who work in health systems have long felt that they were critical to our broader objectives and needed pretty widely. So we're really excited about that. Next slide. So I'm going to talk a little bit about the overall report, and then Rob will talk. There are a series of pages, 2-page spreads for each of the 25 countries, where we typically provide information on progress that has been made and then on forward-looking activities based on the theme of that year's report. So I'm going to talk a little bit about the overview, and then at the end of the report there are a series of what I call technical chapters, but where we look sort of within each of the subtopics within EPCMD, water and sanitation, maternal health, newborn health, behavior change interventions, child health, I'm forgetting one, immunization, family planning. So we look at each of the subtopics and then how they address the theme of the overall report. So I'm going to go through that, and then Rob will talk more about, like I said, the methods and what's on the 25 pages. So in this year's report, we set the stage by looking at an overview of the relative strengths of country health systems, recognizing that health systems are not uniform across the continent, and they're certainly not uniform across our priority countries. What we tried to do was put together an index to give a general sense of the relative performance among the 25 priority countries. To put together that index, we used 3 key indicators. One was the out-of-pocket expenditures, and the rate of out-of-pocket expenditures. WHO sets a target of 15 to 20% for out-of-pocket expenditures, and so we looked at that. We also looked at the density of human resources for health, which again, it has a target of about 34.5. And then we looked at the governance index from the World Bank, which good governance is anything in positive territory on that scale. So, and then we put those together into an index to compare across countries. So as you see here in the example from Ghana, it demonstrates that Ghana is relatively a stronger health system as compared to, on these 3 indicators, to some of the other countries that are our priority countries. But if you dig deeper into it, we see that Ghana is doing very well with respect to out-of-pocket expenditures and the governance score, but has further to go on human resources. And then, so just to provide you with an example, you can see that USAID has targeted our investments to reflect this reality as well. So on the Ghana page, you will see that since last year, USAID, in partnership with Ghana, has supported training institutions to graduate 2,775 healthcare workers, comprised of 1,100 midwives and about 1,600 community health nurses. So our investments are already targeted on the key weakness within the health system, which is supporting the workforce. You will also see that going forward, we're continuing this in collaboration with the Ghana National Health Service to identify new routes to transfer programs and to launch leadership and management improvement projects in 53 districts, which really helps to strengthen the quality of the workforce as well. So that's just to give a general overview to set the stage, so to speak, for our investments. Next slide. The technical chapters of the report is where we really try to talk a little bit more about what we call a systems-based approach. So within health systems, I'm sure you're all familiar with the 6 health systems building blocks, which the World Bank, the WHO published in 2007. Those building blocks, I think, really moved forward the field of health systems by giving us a common work, technologies, and service delivery. However, the downside to the building blocks was that it has the unintended consequence of siloing some of our work within health systems so that we work in workforce or information or governance, when really, as we all know, health systems is really much more integrated in one. We talk about but we also try to highlight how it integrates across different health systems functions. So for example, in the child health chapter, you can read how we work simultaneously to ensure access to and effective utilization of appropriate quality assured medicine in conjunction with strengthening the market approach, and how we draw upon the comparative advantages and complementary roles of the public, nonprofit, and commercial sectors to foster long-term sustainable delivery of family planning information, products, and services to all population groups. The immunization chapter, as you heard yesterday, talks about the importance of sustainable financing because of the transition from Gavi assistance that we all expect to happen as countries grow. The maternal health, similar to what we heard, talks about the importance of motivated, sufficiently compensated, effectively deployed, and capable personnel to manage and provide skilled care. And then similarly, the newborn chapter talks about some of the issues with quality of care that we talked about yesterday and highlights how they link to broader issues of financing and access. Systems play a key role in helping to achieve and sustain key behaviors and really highlight the evolution that the social and behavior change field has gone over the last several years, where they've moved much more to a behavioral economics-based approach to their activities, which really does take more of a systems approach to behavior change activity. the community health system. Read about each of those pieces in each of the technical chapters. And with that, I'm going to turn it over to Rob to talk about the details for the data that's on the 25 individual country pages.
Thanks, Kelly. So what I want everyone in the room to leave today with is an understanding of just how sophisticated the methods were that went into this report. As you all know, they predict that with the efforts that you're all going to do over the next few years, in terms of scaling up health systems, we could save 5.6 million children and 260,000 women. You'd like to know where that number came from, right? Well, if you can understand this slide, you'll understand the entire report. Behind this slide is about 1,000 different numbers pulled from indicators, pulled from DHS surveys, mixed surveys, published literature. And so it was a 6-step process, but behind it was a lot of work by dozens of people to pull as many different indicators as possible from the literature and from published surveys to really get a on-the-ground assessment of the bottlenecks in each country for stronger health systems, what we need to do to fix it, and what would have the biggest impact. So let me walk you through each using 9 on the next slide. We wanted to see what each of the 20, how severe, starting to see where the 1,000 balanced assessment of each country. After we assessed on-the-ground experts, the literature, etc., we put it into a big computer tool from Hopkins. That was a lot, 6 WHO building blocks that were all task shifting and redeploying health staff. Robust predictions for what's going forward as well as for accountability. And so, the next 4 years, they can save about 150,000 children, as well as the, you can really start to set up some accountability and some advocacy over the last decades to calculate this. So here's one of the 29 strategies. And then just to finish up, so this is what each country looks like. So we saw earlier that this is what the aggregate looks like. Bust analysis over because there's a lot of
the rest of the data that's on the those slides. You'll see this cultural analysis with each situation, total number that for those who are not as well versed, you see that they quality health services, but the increase over the baseline is actually great services. This is women who would be having children do not have capabilities for emergency obstetric care. So you see where we are increasing access to quality as well. Next slide. To improve access, are happy to report that working with the government of Ethiopia, we've helped to increase pentavalent and measles vaccination coverage. We've reached 2.5 million women with maternal and child health and family planning information, which has led to 41,000 referrals to public sector health facilities. And then even further see.
Hi, I'm Jonathan from DRC. And I have a quick question about the, you saw a slide with the approach system, and we know that USAID doesn't fund systems, but specific sectors. So how do you think your funding could improve the system if you put money in a transversal programs?
Question. The slide that has all of the interventions country by country is not meant to demonstrate USAID's effort alone. It's meant to demonstrate the collective effort of all actors in country. So when we asked country teams what was happening, they gave us responses that was not just USAID's work, but what they knew, and this was USAID and USAID country teams, and often in consultation with governments, what they knew was happening and what level they would expect it to scale up to. So a couple of notes on those bars is because that's the way the question was asked, is sort of what level is it at and what level do you expect it to scale up to over the next 20 years, or the next 4 years until 2020. The interpretation might be different. So a short little bar might mean that it's an intervention that's just being rolled out and is not expected to scale up very high. Or it could be an intervention that's already almost at scale, and so the additional scale up over the next 4 years is not expected to be very great. So a lot of the data on this page you need to interpret with your knowledge of the country to understand why something is coming out as lower than expected or potentially higher than expected. In addition to that, I think it's also important to note that the interventions are not necessarily they're also one other thing. So it's also important to note that they're based on what the critical bottlenecks. So a intervention that was going to be scaled up significantly, for which there weren't really bottlenecks, would not have as big of an impact as interventions that were expected to be scaled up significantly, for which there were also considerable bottlenecks that we're addressing. So it all sort of plays together to produce these results. So it is very country specific, but I think hopefully relevant at the country level. So as for USAID, we, because these are not necessarily activities that we're supporting, but some of them are, and then, you know, there's nothing that prohibits USAID from supporting any of these activities. I know our funding comes in child health of the importance of interventions. Those are conversations that USAID missions can have with countries on the ground about, you know, whether or not we are capable of supporting an individual intervention or not. So did that answer your question?
Yeah, but I would like just to know about, because as you said, you just like put sometimes money on specific program and areas, but how do you think, like in general, the funding of USAID could help the system?
So yeah, so the funding for USAID, because our funding is directed towards results, so we think that something like this, which connects the systems to the results, is very useful for being able to make the case both within USAID and within countries about the importance of supporting health systems. But largely, the funding that USAID has is always directed towards achieving a set of results. And so we need to understand the country context, and we need to be able to link specific funding to the results that we're expected to achieve. And if we can make that case and it makes sense in the country context and it makes sense within the broader portfolio of the mission, it's the kind of thing that we can fund. But so we view this kind of work, we think it's helpful now for USAID as we make the case to say that health systems can link to results, and really that's what we're happy to demonstrate. Another question? Yes.
Yeah, thank you. I'm from Uganda. I just wanted to know the meaning of those colors. When you go to the next slide, it's as if all the is that orange, or does it mean in those indicators we are doing badly? The green, the blue, and what do they stand for?
Thank you for bringing us back to this slide, because I went through it a little quickly. So I guess maybe the legend is too small. Each color is simply a different of the 6 health system building blocks. So red, so no, it doesn't mean you're doing badly or well. It's the red is the service delivery. So that what you're looking at, this is a number. The different sizes of the box are the number of lives saved over the next 4 years out of the total of 5.9 million, 5.6 million children, 260,000 women. So that 5.9 million is included service delivery, for example. And so in the full analysis, we expect that 700,000 children will be saved as a consequence of increasing CHW service delivery. So that's a big box. The box next to it is quality improvement. It looks about 600,000. So the different colors are just for interpretability, but obviously it required some more discussion. So green is human reach. So in order of size, red is service delivery. So you're going to get the biggest bang for your buck there, at least under the circumstances, under the limitations of this analysis, from service delivery, followed by green, human resources. Purple is financing. Blue is commodity, supply chain, things like that. Orange is information, and gray is health system accountability. There's only one variable in gray, which is why that box is smaller than the others. Not necessarily that that's not important, but it's actually bigger than some of the other boxes there. So each box on this slide represents a number of lives saved in all 25 countries aggregated, and then here disaggregated.
And I'll just add to that most of the data in the report is a projection to the future. So it is not a value judgment on whether anyone is doing better or worse than anything else. It is meant to be, you know, if everything goes perfectly, if we can do all of this, which we think we can, this is what we could achieve. So the only thing that is not forward-looking is, somebody showed the racetrack graphic the other, I think it was Stefan, the other day, and that's on the left-hand side of the country pages, but that is also not necessarily a reflection of actual work in the country, because what those data are is projections from the most recent DHS data, assuming linear increase. So assuming that whatever trend line you are on, you stay on, and then comparing that against our original targets that were established in the because most of the DHS surveys occurred before 2014. So even that data is underrepresentative of the actual situation in most countries. But what it is meant to do is it's meant to say, here's something we should keep an eye on. You know, we might not be on track to achieve those targets. Let's stop and think, is it the kind of thing that, is there more we can be doing?
It's a question, and my name is Moses Dombo from Uganda. My question is on, I have two questions actually. One is on reliability of the data. I know that many times, even the ministries of health, and particularly the Ministry of Health from my country, sometimes they doubt their own data. And so I'm looking at reliability. Sometimes people report good figures to impress. Sometimes people report bad figures to attract resources. Two, and a package or the investment
data point. So when possible, we used ranges. So we didn't just use 1 point, we used a low estimate and a high estimate. The point, there was no ulterior motive of attracting resources or showing progress. We really just wanted to see what is the real number. So, I mean, that still is subject to the limitations of, well, how good are those original real numbers? And as far as that goes, the way we mitigate that is by using a range rather than could be off by a factor of 10 to 20% in either direction. I mean, that's definitely correct. But in terms of reliability, I think we probably have an accurate number, although it may not be that precise. It may have some error bars around it. Now, that's the first part of your question. To the second part.
Sure. So so again, I think the data that's on that page is meant to start a conversation. And I think it really does require country-level conversations with people with on-the-ground knowledge of what's happening. We do caution against trying to use it as a prioritization exercise because the way the model works is it assumes everything happens. So if you were to say, oh, I'm just going to focus on the big bars, it would actually change the results. So it's less an exercise in prioritization, but more an exercise in having the conversations to make sure that the things that can be, you know, if based on your knowledge it's due to large scale up, or if something has happened which would impede the scale up of that, maybe that's something that should be focused on further because there is a significant number of lives that could potentially be saved by that intervention. One of the things that we're doing in Washington is, as we were going through the report, we noticed that of the 25 countries, 22 of them had noted enhanced supervision as one of the interventions that they were working on and waived. And so we're asking ourselves, do we know enough about enhanced supervision? Do we know enough about what is a quality program? What is the best way to implement that? How can we support countries to make sure that we're sharing lessons learned and best practices so that we can really realize those potential lives saved from that? So that's an effort that we're trying to do to collect that information and share it further. And there's further insights that I think you could glean by looking at the data and having conversations, I think, with your UNICEF and USAID and country counterparts. Because again, what it is it's an expression of potential.
Basically, really following up on that, Africa being the case in mind, we've tended to look at the Abuja Declaration as a benchmark. Recently, I participated in another conversation of a primary health care strategy development group that was putting forward a figure of $86. I think coming from somewhere in one of the universities in London. And we know WHO has thrown numbers out there, $44. But we know that in most of our governments, but we know that they are working with very limited resources against competing needs, against very fast-growing populations. And so sometimes without any conversation, That is 40% of the budget. What about security? What about X? What about Y? So I think one of the things that may be helpful, and I'm not saying that you do that here, is if you can use some of this data to facilitate dialogue which says, okay, for countries like Ethiopia that have made significant improvements, they started somewhere. They emphasized some things over others, and they made traction. We can't move everything at the same pace, but if we are going to make significant dents into this
guidance, the original 2014 report that we did, which modeled the child health interventions based on the LIST tool, we used what we called the best performer model. And so what we racetrack graphic that are based off of that represent what we call charted at a similar place. You could achieve the rate that the best performer had ever done in the past. Not necessarily, but it is a more realistic country-specific benchmark. And so there's a similar idea with the modeling that we did this year, because we asked the countries themselves for each of those where they were starting. So perspective is we were using it in the aggregate in a is very low country level, and really to a country and plan it out and use it for a prioritization exercise. So, and that's something that UNICEF supports within the countries. So I think if you're interested in this usual approach to the EQUIS tool.
For those of you that have the report with you, I would ask you to take it out and look at it, if anyone wants to do that. Some people have it, great. But all of the experts that we consult can read it. But under service delivery, for example, we put scaling up quality improvement at a level that is possible. So for an advocate like yourself who can go to the government and say, listen, you know, we have a child lives saved over the next 4 years, so let's make a plan to make sure we hit the quality improvement scale up. And you know, if you're interested, if anyone's interested, we can certainly get you the numbers back behind this, and happy to discuss in further discussions, and to use the EQUIS tool, the EQUIS out of UNICEF. They're very proud of it, and they're coming individual country. You can see what we project is the, sir.
As you presented this very useful sheet, if you consider the equity perspective, then if we don't segregate people, equally we are distributing our resources for the whole countries to achieve this target, then it may, you know, drawback, but they're needed. I'm just giving an example from our country in Bangladesh. If you consider that malnutrition is highest in the urban slums, is it possible to segregate your result by the urban and rural perspective? And my understanding is that there are messages of the urban and rural globally too.
So yes, that is and done at sort of national level report that we did last. The two reports actually, bottlenecks are more critical at or are more important when you're trying to address unequal or excluded populations. You'll also notice the bar chart on the far right. So for each of these interventions, they have an impact on, each of the health systems interventions have an impact on different levels and different care systems. So we've divided those out. So there's the community-based practices, the preventative care, the delivery care, and then the care for child. For example, vouchers was one of the interventions that you were going to scale up. The way that the tool works is it would look at what that scale up was on vouchers, and then EQUIS is able to model that impact to say, okay, so maybe the voucher is for delivery care. So all of the impact would be on that delivery care component and the bottlenecks that are impeding delivery care. You wouldn't have as much impact on care for child illness because it's a maternal health voucher. And similarly, other interventions, for example, community health workforce, potentially expanding CHWs, that would have an impact at the community level, potentially at the preventative level, and also possibly at the other, but they're not necessarily providing delivery care. But the way the tool works is it actually segregates the impact based on each of those kinds of packages. So there is some thought within those total numbers about how it's impacting bottlenecks at each of the levels of care. And then finally, just back to my continued paid advertisement for the EQUIS tool, and I don't know if there's someone here who knows it better than me, but my understanding is if you do the tool, if you go through the tool, you can start with segregated populations. So you could start by saying, I only want to look at the rural population, and then if you, to the extent you have the country-specific data on that, you could use it at a country-specific level to get the disaggregated results. We couldn't really do that when we were trying to aggregate across 25 countries, but my understanding is if you have the data at country level, you could do it that way as well.
I will just add one thing. So she's absolutely right. The Equist tool allows 3 different forms of equity analysis. That's what Equist means. One of them is urban-rural. The second one is wealth, where you can target a specific quintile or 2 or 3 quintiles. And then the last one is a particular population, children, adolescents, that sort of thing. And so, again, I draw your attention to the report in terms of things like community. These 4 on the right here, these are the 4 service delivery platforms that we do try to, you bring up this issue, care, prevent, and our team is available for country-specific analysis potentially, or at least UNICEF or that sort of thing. But what you've talked about can be done specifically to tailor for Bangladesh, and we can get closer down to that level. This is a first analysis of what we hope is several.
I think we have time for 1, maybe 2 more questions. Okay, well, both Rob and I are hanging around, so if you wanted to ask us something less publicly. Other than that, I believe the next session starts at 3. Anybody? I believe the next session starts at 3, and there is a coffee break from now until 3, but let me just confirm that. That is correct. So there is a coffee break from now until 3. We are happy to answer individual questions, and then you should be back here at 3 for the final session of the day. Thank you all for coming.
Yeah. The camera focuses you automatically.
Oh, really?
Thank you. Okay. Thank you.